it going. Welcome this evening. If everybody could make sure you're muted. I know in big meetings like this that gets to be a problem a little bit later on. But thank you for being here. I know that there's a lot that you can be doing with your evening. You have a lot of places you can go for PT education and involvement in the profession, and we appreciate so much that you chose to be here with us tonight. I'm really excited for tonight's presentation by Dr.
¿Verdad?
Janey Prodoehl, and she's an expert
Sí.
in TMD and really doing just about everything she can in the profession in that specialty, advocating within our profession, advocating to other professions so that we're recognized as providers in temporomandibular disorders, and advancing the research so that our practice and care improves. Before I send it on over to her, let me highlight a couple things that are going on in APTA Orthopedics. First of all, student membership is now free. So if you know any students who are APTA members, they just need to go into apta.org, find the academies and sections area, and click on orthopedics. And that's it. They will be members and have access to all of our benefits. Also, while we're talking about free memberships, membership to communities and SIGs is free in APTA Orthopedics. So you can go onto our website and join these communities that are really geared at connecting with other people who share the same interests and specialties that you do. I'm going to list off all the communities and SIGs just so you know. PT, foot and ankle PT, performing arts, imaging, occupational health, pain, PTAs, health promotion and wellness, spine, and students. So that's a way to increase your engagement just a little bit, getting involved in our SIGs and communities. And they're putting out a ton of content on our podcast, which you can find wherever you get your podcasts by just typing in APTA Orthopedics, and also on our YouTube channel. I know imaging in particular has had some great content out there about everything imaging and PT and how you can incorporate it in your practice. Foot and Ankle put out a YouTube video a while back that thousands of us watched. And if you're like me, you're watching it with your mouth agape, just watching them go through a cadaver anatomy course there right on YouTube. It was pretty cool. So check this stuff out. Don't forget to subscribe and like. A couple more benefits that are coming down the pipeline for our members. You will see in your inboxes already some tools coming through from PhysioU, who we are working with. They are producing a variety of these tools for us to take the CPGs and implement them in our practice. This organization started making clinical practice guidelines almost 20 years ago at this point, and I believe they really have changed the profession and the way we practice. They really describe what modern evidence-based physical therapy is. And hopefully these tools coming from PhysioU will help you implement that in your practice and start actually using it in the clinic. Like I said, there's some things that are live already. In the next couple of months, you'll see some more emails coming for e-modules learning and that sort of thing there. Also alongside that, we're hoping around CSM to unveil our certification in CPG competency. And this is a way that I hope people across the spectrum of experience in physical therapy will take advantage of. But I know especially for students and early career professionals that this kind of certification that's orthopedic, musculoskeletal based in our profession could be a way to stand out from your peers as you're looking at employers for your first jobs. And finally, but definitely not least, I wanted to highlight the payment consortium, which we've been contributing to for a couple of years now. And it's working to advance payment for physical therapists across the country. We're seeing wins in a variety of states. A lot of this comes through insurance regulation and in negotiating with insurers to change their policies. These wins come state by state. They come slowly. It takes time. And it takes a lot of funding, which your membership dollars are helping to pay for. So with that, really all this stuff that I've talked about comes from members and happens with the engagement and input of members. So we invite you to get as engaged in this organization as you're able to, and we really appreciate it. And now on to a member who is doing more than her fair share to carry the load. Dr. Janey Prodoehl is a professor in physical therapy in the physical therapy program and College of Dental Medicine Illinois at Midwestern University, Downers Grove, Illinois. She completed her entry-level PT degree in Leeds, England, an advanced Master of Science degree in PT at Rosalind Franklin University, and doctoral and postdoctoral studies at the University of Illinois at Chicago. She has over 30 years of experience as an orthopedic physical therapist. She is a passionate advocate for improving care for individuals with TMD by promoting improved access to care and evidence-supported management for this underserved population. She is currently leading a multidisciplinary team in the development of the TMD clinical practice guidelines sponsored by APTA Orthopedics, and is an appointed member of the National Academies of Sciences, Engineering, and Medicine TMD Forum, where she has effectively advocated for the role of PT as primary providers in TMD care. This can only really happen if we increase availability for PT for patients with TMD, and that is the purpose behind today's discussion. She won an APTA Ortho Innovative Practice Award, which has helped fund her practice toolkit, which she will be presenting this evening, which I think is a great resource source that we can all benefit from and help improve our own TMD practice, whether we're just getting into it or whether we have a lot of experience with it. And one last thing I want to plug, she will be presenting a pre-conference course at CSM, and I'll throw a link to that programming in the chat here shortly. So with that, Dr. Janey Prodoehl.
Thank you, James. Thank you, everybody, for coming. You can hear me okay? Give me a thumbs up, James. We're good. Okay. Really appreciate the attendance and the interest in this topic. It's traditionally been perhaps a little underlooked and underserved by physical therapy. So I just want to reflect back on my very first patient that I encountered that had a temporomandibular problem. Was over 30 years ago, really, and I didn't have any idea what it was because my training didn't extend beyond the neck. But yet this patient was in front of me and I had to sort of try and figure out by going to the old-fashioned textbooks and journals to try and understand. And that started me on a journey of understanding it. And I've always been a little bit baffled by why have we not embraced TMD or TMJ as it used to be called. And I think I'd just like you to take a moment to reflect on where you're sitting. Are you a practicing clinician? Do you see this population? Are you afraid of this population? Were you told this is a specialty area? Are you an educator? How are you covering this in your curriculum? What do you see coming out with new therapists? How confident are they in this area? Like, what are the barriers? And as I've met different PTs across the country and worked with dentists to improve collaboration with PT, some of the main themes that seem to come out of those questions are a lack of standardization in training in entry-level PT particularly, a definite bias that some people believe this is a specialty area of practice that I hope to debunk a little bit here. And then just issues in lack of access to patients during training and early career phases that have sort of perpetuated a misconception that this is a very difficult area to treat and work with. So the purpose and the genesis behind the toolkit was to try to improve confidence in the average PT to manage the most straightforward forms of temporomandibular disorder, which we know from the evidence that if we manage it appropriately, conservatively, initially, about 80 to 90% of these patients will get better. They won't need specialized PT care. They won't need specialized dental or surgical care. So I think in the toolkit, I kind of make a pitch that to reframe your thinking about this area of the body to be no more complex than the spine. Low back pain, I think, is very complex. There's a lot of things that could be causing low back pain. We have to carefully screen out for red flags, but we know how to do that. We know how to consider pain in the context of a biopsychosocial model and etiology. And we know that conservative care first is the right approach for our patients with chronic or even acute low back pain. So why is it different in this area? And again, it probably comes back to how you were taught about this area and how complex or confusing it was made to you to think that there's something magically different about the joints and muscles in this area versus in the neck. I think the neck is way more complicated and more difficult to treat. Yeah, as orthopedic PTs, we don't balk at a patient with a neck pain. So if the barriers are training, then we need to address that at the entry level. And hopefully the clinical practice guideline, which we are about 2.5 years into, will come out, we hope, next year, and that will address the standard of entry level practice. We need to change the rhetoric. We need to go back to our clinics or go back to our, clinical population and say, why are we really not treating this? Is it that we haven't advertised this and patients are not finding us? Have we not reached out to referral sources about this area of practice? And what is the barrier to us personally? Is it our advertising? Is it our clinic knowledge? Is it our forms? Like, what is the barrier? Is it that we've sort of lacked patient experience and therefore we're maybe a little afraid to take the leap? We think that this is complicated, and what if we get a patient that's above us? Well, how can we manage that? And so the purpose of the toolkit is really to empower the PT to be able to screen effectively for TMD in a patient with orofacial pain complaints, to do a basic diagnostic exam with red flag screening, and then basic entry-level strategies for management of the pain or range of motion, mobility, coordination issues that arise. And again, if you kind of flip your thinking to more of a muscle, joint, and movement system problem versus something entirely complex and unimaginable, you'll say, I have the tools to do this. I could start treating this population next week. I will likely be quite effective for the majority of the patients that come to me. I will start to develop a network of professionals in my area that are seeking help from me. I must get 5 to 10 emails a week looking for PTs in different areas of the country because there's such a shortage of PTs. So if you're a practice owner or you're a clinician looking to grow your practice, this is the population for you. You can really fairly quickly and effectively grow your practice, and at the same time you can really meet the needs of this chronically underserved population. So in 2020, the National Academies of Science and Engineering and Medicine released a report on the state of the world of TMD in the US, and it was pretty scathing of all professions about how we have really collectively failed these people. They often end up with irreversible surgeries and chronic and persistent pain because they're not managed appropriately early, which is eerily similar to what we saw in this country 20 years ago with low back pain, when it was very much surgery first kind of approaches. So if we can improve accessibility to great conservative care early, and I believe that physical therapists are the right provider for that care, we have the skills to engage our patients. We establish therapeutic alliance. We understand pain neuroscience. We understand the movement system. We are the right providers to be managing these patients in the acute setting. There are, of course, going to be more complex patients. And so having maybe a small network where you could refer out to some other people that have more expertise in the more complex cases would be appropriate, as it is for any other condition. And finally, from a professional development perspective, this is an area that you could engage in more continuing education if you are really interested. TMD is the most common non-tooth related orofacial pain, but it's not the only one. There are plenty of other conditions and headache conditions, neck conditions, etc., that sort of encompass a smaller, more subspecialty area of PT practice that you could grow and then potentially future certify in. So I would just sort of challenge you to take a look. I'm going to show you the toolkit in a minute, but take a look at it and then think, what are my barriers? Why could I not do this tomorrow in the clinic? What's stopping me? What's stopping me serving my patients, my community? What's stopping me making a name for myself? And then I would just say continue to reach out and advocate for the role of PT. Remember the national campaign from APTA is Choose PT, right? And this is another condition where Choose PT needs to be our mantra. So with that, hopefully I've whetted your appetite to say, what is she talking about? What is the toolkit? And we will see that when we go to APTA Orthopedics webpage, we'll go over here to resources and assess resources, and we'll scroll down and we'll see the TMD toolkit here next to the nutrition toolkit. So when we log on, when we click on to the toolkit, I'm going to view the infographic that just shows what's in the toolkit first. And really, it's got two parts. Part one are 3 narrated modules to improve your confidence and understanding of this condition that go through the etiology of TMD and how it's changed over the years. If you've been out of practice for a long time, out of school for a long time, or you didn't get this in PT school, you would definitely be interested to see how this has evolved and now where this sits in the world of healthcare. And then module 2 goes through basic exam principles. The exams have been validated, the physical exam and red flag screening, and it's the estimated time to complete a TMD exam is about 8 to 10 minutes. And then that is added to your cervical exam and other exam items enough to be able to understand basically what type of or what form of TMD we have. And therefore that will guide the initial management. And so module 3 is the management principles. So all 3 of those are available, and those are about 20 to 30 minutes each. So the second part of the toolkit then is to increase and grow awareness in the local community and provide more outreach. As orthopedic PTs, we are often more comfortable going to orthopedic surgeons. Why are we not comfortable going to dentists and primary care professionals? So this includes a downloadable and customizable PowerPoint presentation that you could use with you to show you the value of PT. And it also has 2 infographics, one aimed at dentists and one at patients to grow the role of PT. Now, the 2 infographics can be shared freely anywhere that you want, any social media posting, your clinic websites, your personal website, wherever that is. The rest of this is housed within the APTA Orthopedics. So if I go back to the toolkit, now how do you access all of that? Well, you'll see part 1. I can click on any of these modules and it will take me to this one is 30 minutes. That's module 1, module 2, or module 3. Part 2, here's an example of the customizable PowerPoint presentation. And then we have a notes page that goes with it to show you how you can actually engage with dentists, who will be probably the primary referral source if you indeed need a referral. I would say about 2/3 of my patient at this point don't come with a referral, they're direct access. And that's because patients are desperately searching for help. So you certainly don't need a referral unless they're Medicare, in which case you do need the referral to come from a primary care physician or another medical professional, not dental. And then we have the 2 infographics, which you can click on. So if we click on the patient one first, this would be good to house in your clinic, share on social media, really try and grow how PT is the right provider for first-line TMD care. And then the one for dentist is, again, something that you can mail to dentists, you can take with you, you can leave flyers, and really shows them how to collaborate and what the role of PT is. Dentists don't typically learn much about any other profession during their dental training. And I know that because I work in a dental school as well as a PT and medical school. And so it's quite innovative to have PTs as part of the education program for dentists. And they are thrilled to know that they have resources for their patients, because otherwise every patient ends up with an oral appliance or a mouth guard because that's the only thing that they can offer. So for them to have another avenue of care for their patients is tremendous. They will love you to death. Remembering, and it's one of the things we cover in Module 1, is that unfortunately dental care itself can be a primary cause of symptoms related to TMD. And then the last thing here, in addition to the PowerPoint, the infographics, is the supporting materials and references. And this includes all the tools and that you would need. These are all validated tools that we would recommend for working and screening with our patients. So there are the full diagnostic trees, but I've kept it to the brief DCTMD, which is the brief diagnostic criteria for TMD, which is expected to be able to be completed in about 10 minutes as part of a comprehensive PT exam. And then we've included that go along with the PowerPoint presentations about what would this look like from a physical exam perspective. How do we tease out whether this is sort of a muscle and or joint, more of a presentation? And then for any educators or people that are interested in diving a little bit more into this, we've included all the references for the different modules, as well as some YouTube videos with exercises and activities, and then free training options for any provider that's interested. I always love to give this reference here. This came out in 24, and it includes, again, more narrated PowerPoints aimed at really growing interdisciplinary care for TMD. And then there are various podcasts. There's a shameless plug for my podcast with the American Academy of Orofacial Pain that was really aimed at trying to educate dentists about the role of PTs. And then the different modules, references as we go on. So with that, I said I would keep it brief. I would love to hear from you as members. What are your thoughts? What are your barriers? What are you kind of recognizing that you could do here with these individuals? And I see that James has put the link into the chat for the CSM pre-conference course. That's a one-day course I'm doing with Dr. Emily Carnett from the University of Minnesota, where we're going to be really putting this into practice. Like, what are how do you do this? And we'll be going through a lot more clinical decision-making tools to help build your confidence in this. So we hope that you can join us for that pre-conference course before CSM in Anaheim.
Janey, we'll open it up for Q&A, but since I don't see any hands going up, I'm going to ask you a question.
Okay.
I mean, what I really want to do is move this clinically. You've given us a ton of resources and tools to look at to grow our practice. And it feels kind of unfair to ask you like, what's a clinical pearl? What's the one thing we should be doing? But here's a clinical question that I did think of is when we see, whether it be in the clinic or we hear, I think of family parties where everybody's pain starts coming out and you start hearing about this stuff. Are there particular things that you see that kind of jump out at you as the care that's inappropriate that people are getting when they haven't been to PT? What are the things that you see happen that make you think, oh gosh, I really need to gently suggest to this person to get to a physical therapist as quick as they can?
Oh, wow. That's a loaded question, James. I think was always tricky when you are working definitely this kind of patient crosses into disciplinary bounds. And it's always difficult when a patient's coming to you with, or even a family member that's pursuing a line of care that is not necessarily evidence supported. It doesn't mean it can't work, but it certainly does mean that in the long run, the evidence does not support that. So the sorts of things that that relates to is a lot of occlusal adjustments, teeth bite positioning, a lot of splints that can lead to irreversible changes, early surgery, things like that. The evidence is really pretty strong that conservative early care is the right approach for the majority of patients. So, for instance, I had a young woman referred to our clinic about a month ago. She's 17, high school student with a very limited opening. No pain, interestingly, but had been quoted, her parents had been quoted a course of treatment that would have cost about $1,000 using a progressive series of oral appliances and lots of testing to get her functional. And her parents were told that if they did not pursue this line of treatment, they would likely have lifelong issues. Now, isn't that the same rhetoric that we often hear from patients with low back pain? If you don't get surgery now, you'll regret it. It'll be what we know from our low back pain, that surgery first is not the way to go. The outcomes in the long run are not as good. Now, there are indications, clear indications, as there are for low back pain, when an initial surgery or an invasive non-conservative approach is recommended, but not for the majority of patients. So indeed, we were able to work with this individual. 3 treatments later, she has full opening and no pain. Now, how much did that cost? Certainly wasn't $7,500. And the parents are like, why did nobody suggest PT? Because nobody had suggested PT to this individual. And that's sort of part of the miscommunication that is out there. Many dentists believe that PTs only work with muscle conditions and they can't work with anything that's joint related, which is sort of baffling. But when you think back to where TMJ came from, it was originally thought to be an occlusal issue. So the way the teeth come together so the treatment was predicated on returning occlusion to normal, so that the muscles and joints would be balanced. That was kind of the initial approach. And then when that didn't work, they kind of moved to more of an oral surgery of fixing the joint problems, and then assuming that the muscles would just follow. And when that didn't work, now we're kind of in the realm of conservative care first, which seems to be having better long-term outcomes for our patients. So I feel like I'm always walking a little bit of a tightrope with patients to not discount other approaches. And it's possible that those approaches can work. And maybe the evidence just isn't there yet because it hasn't been studied. But certainly when I consider the cost involved with many of these other options and the time commitment, why not try conservative care first? Give it 6 to 8 weeks. We did a study where we looked at almost 100 joints that had a disc displacement without reduction with limited opening. So that these people can't open their mouth, they have a lot of pain, and there's evidence on imaging that the disc is anteriorly displaced. If you ask an oral surgeon about those cases, they will tell you that they need MRI imaging to establish that the disc is out of place, and they will tell you that they need a surgical procedure to reposition the disc. And that would be sort of more of the older thinking. In that particular study, using conservative physical therapy care, the average number of visits it took to achieve an acceptable range of motion of maximal mouth opening and patient satisfaction was 6 visits. 6 visits of PT, no surgery. Right. So think about that. Now, there's going to be a range in that. Obviously, that's not the experience for every patient. But why not at least try 6 to 8 visits of PT first? And if the patient is not improving satisfactorily, then consider a referral. That's what we do for all of our patients. We establish a plan of care. We monitor them for improvement. If they're not improving or they're getting worse, then we consider other sources of problems that we may have missed. We consult with a colleague, or we consider referring them on to the next phase. And it's no different here. That was a long answer, James. Did that kind of capture what you were thinking?
I'm not sure. I was having a hard time listening because I was reading all these great questions that people
Oh,
were
there's good
asking.
questions. Okay. Yeah.
I thought it was great, though. I thought it was great. I kid. Thank
Do
you.
you want me to go through the questions or do you want to moderate them?
No, you know what? I've kind of been looking through them, and there's some themes,
Okay.
and I can tell everybody that I'm not going to get to all of the questions, but let me try to bundle a few of these into some themes and ask you that. So
Sure.
I'm prepared to ask you a new question from what we're seeing in the chat. What basic information are you giving to PTs about how to handle jaw locking safely and
Yeah.
effectively? Is it rest and posture, breathing and sleep? Is it treating the upper cervical spine? What of
It's all
those
of
things
that.
would you
Yep.
lean on?
Absolutely. So jaw locking just means that there's something interfering with the path of motion of the joint, just like there can be catching or locking in the shoulder, right? So how would you manage that? Well, first you would try and de-escalate the situation by reducing any symptoms. And often the symptoms are coming because the joint has become inflamed or the muscles have become, irritated, and we have myalgic symptoms. So think about it. If this were a shoulder problem, what would you do? You would decompress the joint. You would promote early pain-free motion. You would promote rest position. You would work on down regulating the autonomic nervous system, up regulating the parasympathetic nervous system. So there's your breathing and sleep and posture. And you would try to restore pain-free range of motion. And that's exactly what you would do with these people.
Fantastic. Thank you. Um, to what extent do you think the upper cervical spine plays into this? What have you seen in the research in that realm?
Oh, the research is pretty strong that there is a strong link between cervical dysfunction and temporomandibular dysfunction, particularly when we get to the chronic stage. What's not clear is the etiology that upper cervical dysfunction directly leads to TMD, but I think that we're not far off of that inference. So when we think about the neuroanatomy, neurophysiology of the area, we know that there's a convergence between the cervical system and the trigeminal system in the brainstem. So that's an anatomical neurophysiological fact. So that means that by the time those signals are getting up into the brain, we don't actually know where they came from. Was the input from the trigeminal system, or was it coming from the upper cervical nerve roots? And I've seen anything down to C5 included in that convergence in the nucleus caudalis. But even if we just consider the upper cervical spine and think about nerve roots 1, 2, 3, maybe, it kind of explains why there's such a strong relationship between neck pain and temporomandibular pain or facial pain and headache. What we don't always know is which came first, is it cause and effect? But I would say any patient that has not necessarily an acute problem, but something a little bit more subacute to chronic, almost always has some cervical involvement. The issue for PTs is to figure out, is the cervical spine the driver of the facial pain, or is it a consequence of moving abnormally for so long? So once an individual has developed pain, maybe the muscles and joints and the motor control of the area start to change, then they start to change the way they move and they start to compensate with other muscles. So I saw a patient just today who I asked her to open her mouth, and she only had 24 millimeters of opening, which is barely enough to even function. Less than 30 is very hard to eat. And as soon as this is literally how she opened her mouth. So I'm going to see if I can show you. She would open her mouth and she'd go, and like you could see the whole neck is, the scalenes are popping out, the SCM is popping out, the jaw is protruding. Clearly, there's just an abnormal coordination of movement there. And that's what we do. We address the neuromuscular reeducation of the area. We'll look at the cervical spine, we'll look at the jaw, we'll make sure those two areas can operate functionally together, but also independently. We shouldn't be seeing a lot of cervical compensations or even lip compensations or eye compensations with simple jaw movements. And I think that neuromuscular reeducation piece is the part that no other profession has understood. That they treat that the orofacial pain specialists often treat with injections to reduce pain, but they don't do anything that actually addresses why did they have pain in the first place? What was the control issue that led to overusing those muscles? We can certainly give exercises to reduce tone in muscles, but if they continue to do the same habits and activities that they were doing that got them there in the first place, those symptoms are just going to come right back. So again, I don't want to I do want to keep harping on it. It's not any different than what you would do with low back pain. You wouldn't just treat the symptoms. You would try and understand the cause and the movement system as a whole. You wouldn't just look at the lumbar spine. You would look at the pelvis, the spine. You would look at the feet and ankles. You would try and figure out, why are they overusing this area? What is going on? And we have all the tools that we need to address chronic pain as orthopedic PTs. It doesn't actually matter what part of the body it is. So if you do nothing else but engage in reducing symptoms, you will be effective with this population.
We, and thanks for that comparison to the spine, because I know you had said it a few times, but I know for me, the way you just described it there, with the scalenes being overactive and other things happening in all the facial muscles, that really helped me see that comparison with neuromuscular training and the other aspects that you described.
Mhm,
We have a couple questions about Rockabato exercises
mhm.
and what you think of them and their efficacy in this.
Yeah, so Marianne Recobado is Anne. Oops, hi, somebody. Is that Anne? Hi, Anne. I hear a child. Um, and he really, I think, did the most initially to shine a light on this area as part of PT practice. The Rockabato 6 exercises, the 6x6 program is pretty standard. But when you break down those 6 exercises, they're all good for different reasons, right? The first part of the 6 exercises is diaphragmatic breathing. Right, and now focusing on relaxation of muscles, perfect. The second one is a controlled opening, where you keep your tongue on the roof of your mouth and you open and close to just allow normal input and movement into the temporomandibular joint. That's exactly what we love to do, right? We love to give pain-free movement, motion as lotion back to our joints. Perfect. When we start to look on the third and fourth, when we're starting to get into isometric resistance of muscles, which is that sort of reciprocal inhibition of muscle activity, perfect. If the muscle is overused, then or in spasm, let's make it relax. Perfect. And then the last couple of exercises are really related to the cervical spine, about improving retraction, deep neck, cervical flexor activity. Again, if I could design a program, it would probably look an awful lot like that. So even though he didn't necessarily have the science behind it, I think he was onto something. And I do use pieces of that Rockabato strategy for many patients, often giving exercises 1 through 3 initially, and then coming back to the cervical pieces. So whether you call them that or you develop them as something else, yeah, I think that is really strong. Now, he has since gone on to do a lot more exploration of the myofunctional piece of this, which is a whole nother level of interest, like the airway, the oropharyngeal area. But if we just keep it basic at this point, I think that's really what we need for the majority of patients. So to summarize, I think the what works for me in the 6x6 program is it's done multiple times throughout the day. It's something that the patient can do. They own an activity that they know will immediately reduce their symptoms. I have a colleague, Steve Krause, who actually he wrote the textbook that I originally read when I didn't have any idea what to do with that one patient. And now I've come sort of full circle, and Steve and I have been working on publishing different articles. So it's been this wonderful sort of circle journey. And Steve Krause always jokes that he's going to come up with the Krause 10 by 10. Like he just wants his name out there. So it's always funny. So what's magical about the 6 is it's breakfast, snack time, lunchtime, snack time, dinner time, bedtime. And really, you just want the patient doing something throughout the day to engage in their in relaxing the area and allowing pain-free or controlled motion. Because when you've got the tongue on the roof of the mouth and you're opening your limited motion, you're not adding that translation piece that can often be problematic.
Wow, thank you. That's very helpful. Uh, there's also a question about intraoral exercise equipment, for lack of a better phrase, things that we can be doing intraorally. What do you have to say about that?
Well, I think my best intraoral tool is my hands. I do a fair bit of intraoral deep masseter mobilization. There's not too many other muscles. You can reach the temporalis tendon, but you can't really reach the pterygoids unless you get to the submandibular and get a little bit of the medial pterygoid. I do use dry needling a fair bit to reach the pterygoids, and that would be a little bit more of an advanced training approach. Certainly not appropriate for every patient. These patients, particularly when they're in the chronic state, are often highly sensitized. and a little bit of pressure, really, they can't even take the manual work, so they certainly can't even take dry needling. But I would say dry needling is something that has really extended my practice in the last 10 years, and I do rely on it for some patients. But I always start extraorally, then move intraorally, and then make sure that the patient is educated on what they can do to promote those sorts of relaxation at home. But I don't use a lot of intraoral equipment. So I had, again, the patient today had very limited opening. And there are devices out there that you can buy. They're about anywhere between $300 and $600 to promote improved opening. I just use a stack of tongue depressors and, add an extra one to sort of trombone the distraction, and it works just as well, saving that more expensive equipment and intraoral equipment for patients who desperately need it, like patients with post-radiation trismus. But that's not the kind of patient we're talking about with this TMD toolkit.
Now, you said you start extraorally, and then you tend to go intraorally
Hmm.
doing manual work in there. And I think I've heard you say in the past that that's one of the greatest barriers that PTs identify as to why they don't necessarily include TMD work in their practice, is that they don't
Hmm.
feel they're comfortable going intraoral with the patient. What can you say about
Yeah.
that?
Yeah, it's sort of interesting. And I don't know if it comes back to basic anatomy, that people are just not comfortable. I think originally, when I first went to my very first continuing ed course, we were trying to palpate muscles that I now understand you have no business trying to palpate. You'd have to literally gag somebody in order to touch that muscle. So it's not as complicated as it seems. If you look at a basic anatomy text, you will understand how to engage and how to reach the masseter. It's not the cheek muscle, it's all the way back there. Intraoral joint mobilizations, obviously, those are pretty basic entry level. Distraction and anterior glide are probably the two most common and most useful. Um, I think the thing that one of the barriers, so in my work with NASM, National Academies, we put out this national care guideline that totally puts PT right in the front of, well, you need to go and see PT early, right? Um, and also, we're trying to educate primary care providers and family medicine providers to appropriately refer these patients to PT early. But the biggest issue that we found is that this is not included in the medical training. So most primary care providers get nothing on TMD. They just know that it's a dental problem and go and see your dentist. Well, the problem is it's not a dental problem at all. So it's like these patients get stuck in this loop of nobody owning them. And one of the barriers for medical providers has been that they are not trained to look or actually touch inside the mouth. And think about it. What would you need in order to do that? Well, you would just need a little flashlight and a tongue depressor, and you're just kind of looking for any gross lesions that you might see. Those would be red flags. And I kind of, and so a dentist asked me once, are PTs trained to do that? And I said, I think they could be. It's kind of like we tell our students that we're not screening for skin cancer deliberately, but we are looking at skin all day long. And if we see something on a patient that doesn't look right, that fits those ABCs of skin cancer screening, it's our responsibility to tell the patient and alert them to talk to their doctor about that. And it's the same in intraorally too. So it's not just touching inside the mouth. Obviously, you need a gloved hand for that. But it's also looking in the mouth just to make sure that there's no obvious lesions in there, because unfortunately the oropharyngeal area is a primary source of cancer. But those are not going to present as typical TMD. Those are going to present a little bit differently. And so in the toolkit, we do talk about those red flags and what you would look for and see. So they are a little bit, but I think we had a challenge in Illinois to our Practice Act by the one of the dental societies here, who said that PTs were not safe to evaluate TMD because they would miss red flags. And so it ended up having a change in our Practice Act language. This is actually what got me hot under the collar and mobilized to go on the road with this, because I think PTs are the primary musculoskeletal provider. We do the very best screening we can to rule out our red flags. We consider yellow flags. We consider blue flags. We have black flags. Like, we are so flag driven, right? I feel like with our OSPRO tools and our general screening, I think we are right up there. I just went to see an orthopedic surgeon for some orthopedic issues I'm having. There's no screening going on there. They're just right to the joint, right? So I think we have to rely on our training and make sure we have good clinical practices for our screening. And then we just have to get over the discomfort that we might feel in gloving our hand and putting it in. But here's the wonderful thing about this, James, is you could put a glove in and do all the palpation on yourself first. And you can make sure that you're touching the right muscles. You'll know what it feels like. And once you've done it on one patient, it's really quite easy to do it on the other. I think I often get PTs ask me if they were never told how to treat this area, right? So I'm thinking about that. Like, what is it that if you were probably not given a script or a protocol for treating low back pain either, but yet you understand how muscles work, you understand how nerves work, you understand how the movement system operates. You can absolutely design program. I saw somebody in the chat talking about breathing and posture and movement. Absolutely use all of your knowledge for this, and you will be very effective. We just actually published a study that looked at confidence in dental students in TMD, because that's another area. So I naively always thought that dentists learned TMD, like this would be their bread and butter. Well, guess what? They don't. Only 3 years ago has it been mandated that TMD education be included in dental education. So that means there's a whole bunch of dentists out there that don't know anything about this. And not only do they not know about it, they don't know anything about the role of physical therapy, which is again part of the efforts to educate our dental colleagues about how we can partner um, to really serve these patients. So one of the biggest barriers that we found in competency was just exposure to patients. So dental students that had no exposure to patients obviously were not confident. They had the book knowledge, but they didn't feel confident. Exposure to up to 3 patients significantly improved confidence and competence. So I see that in my PT students. We have an activity at the end of our musculoskeletal eval course where we recruit patients from the surrounding university community. And we always get a couple of TMD patients. And without doubt, the students that get assigned to those are like, oh no, here we go. Like, could I not get a shoulder? And then at the end of it, they're so afraid. And by the end of it, they're like, that was awesome. I totally got it. Like, it totally made sense. And so they're converts. It only takes one patient to increase your confidence. And then I love it when I get a patient that's beyond my capabilities, because now I really got to dig deep and reach out and collaborate with others. And to me, at the final years of my career, that collaboration and that challenge is really what I look forward to every day.
Fantastic. You were talking about red flags and various concerns of care in there, and there is a question in the chat that's been there for a while, relating to fractures and appropriateness of care with
Mhm.
fractures.
Mhm.
Specifically, it's about a fall resulting in a condylar fracture in a
Mhm.
geriatric patient who has malocclusion. What would you say about cases involving a fracture?
Yeah, I tend to think about it like the Canadian C-spine rules. There isn't an imaging rule for TMD, but I think many of the same principles apply. When you have a patient that's had a trauma, you always assume that there might be a fracture, particularly in our elderly individuals or anybody that it fits the risk factors. So how would we recognize a fracture in anybody, right? We would have significant pain in a, problems. They would be splinting the area. They wouldn't want to be opening their mouth. They would be exquisitely tender to palpation or vibration. But I would say any patient that comes to me with an immediate history of trauma, I usually refer them for imaging before I see them. But that is not the majority of patients. Most patients who suffer a fall or a trauma and experience excruciating pain end up either at their primary care provider or in the emergency room. So I don't think I can count. I don't think I've seen a patient recently that's had a trauma. Now, what I do tend to see is after the trauma, 3, 4, 5 months later, where they were not handled properly initially because they were not told how to manage that, and now they have a malunion. That's changed the mechanics of the joint. That's probably a more complex patient that would not be addressed in this toolkit.
I think we're coming up to the top of the hour, and we've asked a lot of questions. And I think I'm so excited to see all the engagement and all the people that showed up for this. It's really been fantastic. Um,
Well, can I
and
just say that can I just finish by saying how very
yeah,
much I appreciate APTA Orthopedics and their support, because honestly, I've wanted to do this for so long. I'm really passionate about improving our care and really shining a light on PT. But the barrier has always been, how do you disseminate this? How do you get this out to people? And to make this a free member resource, I think is tremendous. And again, I hope that when we get the CPG out, that will change entry level training and that will change entry level practice. And the surgery community has told me to expect 8 to 10 years before practice changes, but to conservative care first. But I really hope it's going to be quicker than that. And I say go forth and start serving your community. This is really a call to action.
and that sets me up for a perfect plug of our Innovative Practice Award, of which Dr. Prodoehl was a recipient and able to put the toolkit together for. So keep your eyes out in your email boxes for the Innovative Practice Award. If you have a topic that you think you're doing something that needs to be expanded in PT and you want to share it, feel free to apply to that as we move forward through this year. Um, I see a question about CEUs in the chat, and maybe someone can assist me if I'm giving the wrong answer here. There won't be any formal certificate for this course or CEUs awarded for it, but I know in a lot of states you can get credit for this sort of thing. And
But if
we're
you
happy
come
to
to our
assist.
pre-conference course, you can get CEUs, right?
Fantastic. All right. Thanks so much, everybody. I
Thank
really
you.
appreciate your attendance here and your engagement with APTA Orthopedics. Have a great night.
Thanks, James. Thanks, everybody. Really appreciate it.